Thanks to the organizers and to the Summit Chair for inviting me today. So I'm going to start off a series of the next several talks speaking about treatment for CLL. I'll kind of give an overview of current thoughts about frontline treatment for the so-called fit patients and show some data regarding recent trials. A lot of those trials will be discussed in more detail by the subsequent speakers. So we're all familiar with the evolution of treatment for CLL, starting with chlorambucil and then the introduction of fludarabine as a purine nucleoside analog. This was reviewed by Michael Halleck about 4 years ago at ASH. We started using combination therapy, and in particular combination chemoimmunotherapy represented by the FCR regimen. Clearly you see an evolution of response rates as well as an increase in complete response rates over time. And so that led to sort of a simple concept or algorithm of how to approach treatment. This was discussed by John Gribben, and it also introduced the concept of performance status poor versus fit patients. Pretty simplistic here. If you can't tolerate therapy, we'll give you chlorambucil. And if you're fit and you don't have the 17p deletion, we'll give you FCR therapy. Tate Shannenfeld reviewed this in a little more detail at ASH last year in, I think, a nice conceptual approach looking at the different regimens and their efficacy versus their toxicity. And so you can see at the right-hand side here, we have chlorambucil in terms of least efficacy compared to other single agents or our chemoimmunotherapy regimens, FCR at the peak here. And toxicity, our old friend single agent rituximab with the least toxicity, you can see that it doesn't even show up on the efficacy curve here. But it gives insight as to why this is widely used as a single agent in the US, because it's just so well tolerated. And at the other end are chemoimmunotherapy regimens. So clearly greater efficacy at the expense of greater toxicity. So that led to a very simplistic view. This is from Michael Halleck at ASH last year, looking at the patients who we traditionally do not treat, the asymptomatic or lower stage patients, those with active disease who are fit, who don't have the 17p deletion. We're going to give FCR to. Standard therapy, standard approach. And that's really on the basis of two large experiences. This is the MD Anderson experience of a longer-term follow-up, 6-year follow-up published a number of years ago. Be interesting to see the curves now. But here's the FCR regimen with at 6-year overall survival of 77%. This middle curve is actually FC in combination with mitoxantrone, and then the single agent fludarabine data here. That experience led to the large randomized trial that you're all familiar with from the German CLL study group, CLL8. Remember, this was physically fit patients, and this introduced the concept of the SIRS score, the cumulative illness rating score, first published for use in geriatrics, but it's basically a glorified review of systems. So the more medical morbidities you have and the greater their severity, the higher the points you get. And the other aspect of fitness was the renal function. So if you had a creatinine clearance greater than 60, that was considered normal. So good renal function, less comorbidities, randomized to FC versus FCR. And here's the punchline, a benefit in terms of overall survival in favor of the FCR regimen. So adding immunotherapy to a standard chemotherapy backbone, prolonged survival in CLL. When one looked at a multivariate analysis for a large number of factors, including some of the higher risk genetic features, as well as the immunoglobulin mutational profile. You can see pretty much across the board in terms of progression-free survival or overall survival, there was a benefit to adding rituximab to the regimen. And in particular, you can, there's a couple messages here when looking at the genomic subgroups. One is that the 17p deletion patients do poorly regardless of the regimen. And the second is that there's a benefit to adding immunotherapy in patients with the 13q deletion or with the 11q deletion. So that's FCR, but let's not forget about FR. This is updated data from the CLGB in the North American, well, actually an original CLGB trial presented by or published by Jennifer Wyek 2 years ago. And this is 10-year follow-up of the trial, so a very long-term follow-up. This was comparing two different ways of giving rituximab with fludarabine. The way we do it these days is a concurrent regimen, and you can see overall response rates quite high, CR rates 50%, but overall survival quite respectable with a median follow-up of 10 years. So keep this in the back of your mind. There was a large intergroup trial performed in the US of FCR versus FR. We don't have those results yet. I think it'll be interesting in particular to look at subgroups of patients to see if some do just as well without the addition of cyclophosphamide. Obinutuzumab is a newer anti-CD20 antibody. You'll hear more about this in subsequent talks because of this trial design using obinutuzumab. Just as a reminder, this is an engineered antibody. It's glycoengineered to increase its affinity to the Fc gamma receptor to enhance ADCC. And then the other end of the molecule is also engineered in order to increase direct cell death and lower complement-dependent cytotoxicity. This was the study that was published in the New England Journal last week, comparing obinutuzumab and chlorambucil to rituximab and chlorambucil to chlorambucil alone. And just very briefly, there was a benefit to either antibody chlorambucil combination compared to chlorambucil alone. This is the progression-free survival, a significant benefit with the antibody chlorambucil combinations. When one looked at the two combinations directly, there was a significant benefit to the obinutuzumab chlorambucil regimen versus the rituximab chlorambucil regimen in terms of progression-free survival, and that's what led to its approval in the US just prior to the end of the year. In terms of overall survival, however, there's no benefit demonstrated as of yet, perhaps with longer follow-up, but we'll have to wait and see. But as a reminder, this trial was designed for less fit patients. Supposedly a better tolerated regimen, but I think it'll be interesting to see if it's used for even fit patients in the US. Next study is the CLL-10 study, also from the German CLL study group. And just to remind you, bendamustine and rituximab has become a very popular regimen despite really a dearth of data regarding the use of BR. There's one published trial previously for previously untreated patients. It's quite amazing to see in the US how people are adamant that this is a better regimen than FCR, better tolerated, sort of a kinder, gentler version of FCR. So the natural trial is, of course, to compare it directly to FCR, and that was done in fit patients with good renal function, a one-to-one randomization, and it was meant to be a non-inferiority comparison for progression-free survival. So here's the adverse events, grade 3 through 5 adverse events, and just looking at this briefly, you could see that there was, and I apologize here, these two numbers should be reversed. There were more hematologic adverse events with FCR, in particular more neutropenia, and more thrombocytopenia, and that translated to a higher risk of infection. So more myelosuppressive, higher infection rate with FCR. Treatment-related mortality was low in both arms. But in terms of progression-free survival, there was a significant benefit in terms of the FCR regimen. The median progression-free survival not reached, 44.9 months with bendamustine and rituximab. Benefit in terms of the hazard ratio as well. So, so far from that trial, we know that FCR will give a better progression-free survival. We don't yet know whether there's a prolonged overall survival. We don't have that data yet, but it is at the expense of some increased toxicity, including increased infection rates. And so the issue of which to use in our fit patients still remains an unanswered question, and still is very much, I think, dependent on the approach or philosophy of the treating physician, as well as the desire of the individual patient. Some patients feel very strongly that FCR is an evil regimen. They don't want to receive fludarabine. They don't want to have chemotherapy. They don't want to have infections. And so that's driving a lot of the choices, if you were, in terms of chemotherapy. So just to summarize, and again, to emphasize, we'll get more detail regarding these trials from the subsequent speakers. I would say that for the fit, or so-called go-go patient, an antibody plus chemotherapy is the standard of care for patients in need of treatment, and I won't give an opinion about which antibody chemotherapy regimen is the best regimen. Thank you.
Okay, thank you. Now